the next session with our update. So, we have Dr. Shri, senior editor from the Paediatric Hospital, presenting today. And the topic is dermatology cases. And actually, we have been informed that we have completed 1 year of the webcasting update. So, on that auspicious note, may I hand over the presentation to Dr. Shri.
Good afternoon, everyone. I'm Dr. Shri, Senior Registrar from the Lady Victoria Hospital. Today, my presentation is on some interesting cases we have encountered in Lady Victoria Hospital for Children. Case 1, Baby Sanuki, 2 years of age. She's a product of consanguineous marriage, and she presented with a fever for 2 months duration since the age of 11 months. And there was significant failure of gaining weight, and there was mild joint pain. On examination, there were widespread erythematous plaques symmetrically involving the face, trunk, and limbs. There was infiltration of nasal mucosa and lacrimal gland and duct obstruction. These are the pictures of the child. There were juicy plaques in the face and the limb, mucosal infiltration leading to a bulbous nose, and lacrimal gland obstruction leading to excessive tears, recurrent eye infections, and nasal obstruction leading to a loud breathing. This is the fever chart, and there was recurring attacks of fever with varying interval. Investigation-wise, full count showed a neutrophil leukocytosis and thrombocytosis, blood picture normocytic normochromic anemia with no atypical lymphocytes, ESR CRP were high, AST ALT there were a mild elevation, serum creatinine ALP was normal, and urine full report showed not any significant changes. Serum ferritin was 1200, ANA was 1 in 100, but repeated was negative. dsDNA complement levels were normal, ENA profile was negative. 2D echo was performed, which was normal. Immunoglobulin profile, including IgD levels, were normal. Bone marrow aspirate and trifine biopsy was reported as reactive, and LDH was 462, which is a very mild elevation. This is the skin histology. We have performed multiple biopsies, always showing a dense dermal infiltration of neutrophils, leukocytoplastic nuclear nebris, and dermal edema. When we consider the diagnosis, the characteristic features were periodicity of the fever and mucocutaneous lesion and synovial involvement. Diagnosis of periodic fever syndrome presenting as sweet syndrome was made. It's a non-association to occur. The patient was offered high-dose steroids, IV immunoglobulin, Dapsone, simvastatin, potassium iodide in different combination for different period, but she only showed a minimal response. So we considered tocilizumab. With that, there was a satisfactory response. Thickness and the number of plaque has reduced, and frequency of relapse has reduced. Probing of the nasal lacrimal gland was done to prevent recurrent eye infection. Case 2, Aditya, 9 years old. This is the recent piece of work of the child. She's a very talented artist. She presented with episodes of high fever, not responding to antibiotic since the age of 2 months. Severe arthritis, and examination revealed erythematous plaques, subcutaneous nodules, and retiform purpura. Current examination, she's 9-year-old now. Current examination, she's having a cushionied appearance, pachydermatocele, trichomegaly, and short stature. These are the pictures showing a cushionied appearance and pseudo-acromegaly due to increased blood flow to the hands and legs due to chronic inflammation. These are the petiform purpuric lesions she had. This fever chart was maintained by the mother, showing the periodicity of the fever. Investigation-wise, she had high inflammatory markers, IgD levels were high, clinical diagnosis of SLCD syndrome was made. She was treated with high dose of prednisolone, dexamethasone, simvastatin, and vitamin C for long period with varying response. Because of this drug resistance, she was also started on IV tocilizumab. After 6 doses, we were able to completely tail off steroid in the absence of fever and other symptoms. Periodic fever syndrome. They are broadly categorized into interleukin 1 beta activation disorders, that is inflammatoropathies, and protein folding disorders of innate immune system. These are the different types of periodic fever syndrome which are identified: familial Mediterranean fever, hyper IgD syndrome, tumor necrosis factor receptor associated periodic syndrome. Toll-like receptor activation initiates the downstream signaling pathways that regulate the transcription of pro-inflammatory cytokines, mainly nuclear factor kappa B. Activation of caspase 1 and cryopyrin complex inside this node-like receptor P3 inflammasome activate interleukin 1 beta and increase production of interleukin 1 beta. These autoinflammatory periodic fever syndromes are monogenic mutations related to this pathway at various states. Periodic fever syndromes, the diagnosis is made on clinical basis. Characteristic features are periodic fever, recurrent synovitis, peritonitis or pleuritis, AA amyloidosis, AA type amyloidosis, and favorable response to colchicine, characteristic cutaneous features, and family history of similar disease. Treatment options available are corticosteroids, statin, colchicine, DMARDs, and interleukin-1 inhibitors, anakinra. Recombinant human interleukin-1 receptor antagonist, which is available in India. For a patient, cost is around 250,000 per month. Both this patient showed a significant response to tocilizumab. It's a recombinant humanized monoclonal antibody of Ig1 class directed against both soluble and membrane-bound forms of interleukin-6 receptor, recommended in severe arthritis and cytokine release syndromes. It is available in MSD. It has a low adverse effect profile. These are some article I found in when I'm doing the literature review. New alternative therapy in dermatology, tocilizumab. They say that satisfying results has been shown in refractory psoriasis, psoriatic arthropathy, Behçet's disease, SLE, systemic sclerosis, relapsing polychondritis, vasculitis, as well as atopic dermatitis. Let's move into case 3. The baby Savisha 1.5 years old, previously healthy child presented out to our clinic with a slowly enlarging growth of the upper lip for 4 months duration. Examination revealed a firm nodule suggestive of a tumor. In December, when the parents first noticed the lump, they have sought medical advice. They have been reassured as it's a resolving hemangioma. Despite reassurance, the lump increases in size, and father has taken a serial photos. This is when she presented to our clinic with a complete distortion of the architecture of the upper lip. Ultrasound scan of the local area suggested whether it's a non-involuting hemangioma or a tumor. They have go ahead with the MRI, and the MRI has reported as multiseptated mass enhancing hemangioma. But physical examination strongly pointed towards a tumor. So we went ahead with an excision with the help of the surgical team. This was the results, an encapsulated tumor with multilobulation. This is the histology, missing pools with thin-walled small blood vessels, suggestive of angiomyxoma. The message in this case is, in clinical practice, think rationally and logically, use the clinical sense. Don't over-rely on investigation or imaging modalities if they don't tell you. Case 4. Baby Okita Baby Okita, 8-month-old baby, presented to our clinic with severe developmental delay. He was referred from the neurology clinic. Examination revealed pigmented dilution of hair and skin with spangled white hair. You can appreciate the pigmented dilution of the child compared to the complexion of the father. This is the hair microscopy showing pili-torti 180 degrees twisting on its own axis. Serum cerebroplasmin levels were low. We are awaiting ATP7A genetic testing and exome sequencing. Clinical diagnosis of Menkes kinky hair syndrome was made. Menkes kinky hair syndrome is an X-linked recessive multisystemic neurodegenerative disorder where there is loss of function in ATP7A gene leading to insufficient copper transporting ATPase, which is required for copper absorption and hemostasis, leading to low copper levels in blood, liver, and hair. They develop normally until 2 to 3 months of age. They present with failure to thrive, lethargy, hypothermia, hypotonia, seizures, and developmental delay. Anemia and bone changes also noted. Dermatological features are chubby cheek, a cupid's bow of the upper lip, and horizontal eyebrow. They have characteristic finding in hair shaft. They have alopecia and abdominal hair shaft defects, 100-degree twist of hair, which is pili-torti, segmental shaft narrowing, monolithics, and brush-like swellings of hair shaft, that is trichorexis nodosa. Hair is light in color, sparse, fragile, and kinky. Diffuse cutaneous pigmented dilution due to decreased activity of tyrosinase, which is a copper-dependent enzyme. Investigation-wise, low serum copper levels, low cerebroplasmin level. The condition is fatal in 90% of patients. Death occur within 3 to 4 years of age. Copper supplement should be initiated before 2 months of age. Copper histidine subcutaneously given should be continued for lifelong. we'll move into case 5. This is a 10-year-old girl. She has Kippel-Tenami syndrome with limb hypertrophy. She presented to the clinic with rapid enlargement of the limb, which causing a disfigurement and a huge impact on his psychosocial aspects. This is her picture. Another girl, 5-year-old girl, patient with type 1 neurofibromatosis. Father has a similar disease. On examination, there was a large plexiform neurofibroma in lower back with multiple Caffeolian macules. The patient was complaining of rapid enlargement, which causing an entrapting neurogenic pain.
That's what that is a plexiform. It's really
This is an 8-year-old girl with glomerular malformation of face, which showed a poor response to propranolol, and there was a disfigurement of face as well. The ill-defined firm nodule, which is less compressible than other venous malformation. We tried everolimus in above patients. They show promising response in early phases. Everolimus is an mTOR inhibitor. It's a derivative of rapamycin, similar to sirolimus, available in government sector, brand Certicon, 0.25, 0.5 and 1 milligram tablets. There is another brand which comes in 5 milligram and 10 milligram tablets. It's an anti-proliferative, immunomodulatory and anti-angiogenic properties have led off-label use in range of dermatological diseases of genetic, inflammatory and tumoral origin. Genetic disorders are tuberous sclerosis complex, neurofibromatosis type 1, Peutz-Jeghers syndrome, vascular abnormalities, capillary vascular malformation, Faces syndrome, capaciform hemangioendothelioma, and other venous lymphatic malformation. Inflammatory disease like graft versus host disease, resistant autoimmune bullous diseases, oral erosive lichen planus. In skin oncology, non-melanoma and melanoma skin cancers, Kaposi sarcoma, and cutaneous T-cell lymphoma. Adverse effect reported are infections, hyperglycemia, hyperlipidemia, pneumonitis, anemia, oral ulcers, acneiform eruption, and paronychia. This is a review of use of sirolimus and everolimus in dermatology. This is ongoing clinical trials which use mTOR inhibitors in dermatological diseases. We'll move into case 8. Baby of Kumari, 24 days of age. She's a product of non-consanguineous marriage with no pre or perinatal complication, with no family history of skin diseases, presented with high-grade fever and generalized erythematous plaques and pustules for 5 days duration. This is the child. This is the close view of the child, neonate. Investigation-wise, full count shows eosinophilia and neutrophil leukocytosis. ESR, CRP were high. There was hypoalbuminemia with normal charactered serum calcium level. Diagnosis was made as neonatal pustular psoriasis. It's a rare entity. Sudden onset of generalized sterile pustules disseminated over the trunk, extremities, nail bed, palms and soles. Predilection for the flexures and dietary areas. Complications were dehydration and sepsis. Differential diagnosis we have to consider is DIRA and DITRA. DIRA is deficiency of interleukin-1 receptor antagonist, which is an autosomal recessive disorder, presented with pustule, osteolytic bone lesion, arthritis, and hepatosplenomegaly. They show a spectacular response to anakinra. DITRA is deficiency of interleukin-6 receptor inhibitor, similar above features, but with no bone changes. Baby was treated with acitretin with supportive measures. The baby showed a dramatic response. This is a patient we encountered yesterday, that 15 years old boy investigating for pancytopenia. He had lymphadenopathy, renal calculi, hepatosplenomegaly, and delayed puberty. Dermatological features were generalized ichthyosis with multiple pinpoint and confluent hyperpigmented macules around bilateral ankle region, fading towards the thigh. Dilated veins in lower limbs. These are the pictures. You can appreciate the dilated veins in the lower limb with hyperpigmented macules. This is showing a generalized ichthyosis. Histopathology done in another hospital was reported as granulomatous inflammation. We have asked for a second opinion on that. Clinical diagnosis was made as paroxysmal nocturnal hemoglobinuria, Budd-Chiari syndrome, that's venous thrombosis of hepatic vein leading to hepatosplenomegaly, generalized ichthyosis, which was caused by widespread venous occlusion, and dilated veins in the lower limb due to occlusion of small veins in the lower limb. Majority do not show an occult hemolysis because this patient didn't have any evidence of hemolysis. Testicular failure and hypothyroidism due to interrupted blood supply for that organs. Few words about paroxysmal nocturnal hematuria. It's a complement-mediated destruction of RBCs as well as platelet, leading to activate the cascade of thromboembolism. So it's a mutation caused by deficiency of complement regulating proteins, that is CD55, CD59, and CD8. Screening test is Hum test, and which can be confirmed by flow cytometry for CD55 and CD19. Treatment eculizumab directed against C5 complement. That is the end of my presentation. I would like to thank my clinical supervisor, Professor Chamini Seniratna, and Madam Shriyani Samaravira, and all my colleagues of Dermatology Unit, LRH. And thank you very much. I would like to thank the President and the Council of SLCD for giving me this precious opportunity.